Title now. Great, welcome today to session 8 of Oxygen Therapy and Critical Care case-based series. Today we'll be talking about high flow oxygen therapy and NIPPV for adult patients. With us today we have Dr. Papytcho, who will be joining in a few minutes, and then Dr. Hope Fury and Dr. Sibukundaba. As usual, we will be using the chat function for questions and answers, which is at the bottom of your screen. So if you have any questions, please feel free to introduce yourself in the chat or ask questions through there. If you have any IT issues, send a message through the chat and we'll help you as soon as possible. And the session is being recorded and your attendance is consent to be recorded, so thank you. If you have any sound issues throughout the session, you can try one of these tips on the screen. On the phone, there's a speakers on the top left you can try clicking on, or switch to headphones. And if neither of those work, log off and log back in, and sometimes that'll fix the issue. So with that, we're very excited to have Dr. Sibukundaba leading us today, and I will turn it over to him to start us off.
All right, thank you so much, Sarah, for that intro. I would like to welcome everyone once again to this very, very exciting session. It's a very, very important session because it's a topic that we've been dealing with every day with respect to COVID-19 patients. So today we are going to discuss ARDS in detail. So today's session is actually entitled Defining ARDS. And so you all must be aware by now that ARDS is a common complication and also a syndrome that defines the critical stage of COVID-19. So it's therefore important that we spend some time to discuss details regarding its definition criteria, its management in detail, and some of the complications that can arise if we don't manage ARDS appropriately. So as per tradition, we are going to use a case example or a case scenario who presents with hypoxemia and respiratory distress. So our session today, before I go through some of the practice change objectives, our session today will be divided into 4 parts. The first part will discuss respiratory failure and hypoxemia. And then the second part will discuss details regarding ARDS or defining ARDS itself. And then the third part, we'll talk briefly about the important management aspects of ARDS. And then part 4, which is the last part, will break out into 2 groups and discuss just 2 practical aspects of managing ARDS. So our practice change objectives at the end of this session will include, we should be able to define what respiratory failure is, as well as be able to list the types of respiratory failure. We should be able to define hypoxemia using pulse oximetry, as well as using an arterial blood gas analysis. We should be able to list the criteria for the definition of ARDS. We should also be able to apply the diagnose ARDS. And then we should also be able to describe ARDS in terms of its severity. What is mild ARDS? What is moderate ARDS? And what is severe ARDS? We should also be able to discuss briefly the pathophysiology that occurs in ARDS. What is the underlying pathology? What is the problem going on in the lungs as a result of ARDS? Then we'll list some of the principles of management of ARDS. And one of the key things that we consider is lung protective ventilation. For those patients that end up on invasive ventilation, what are the principles regarding lung protect? What do we mean when we say lung protective ventilation? We also need to go further and understand what parameters on a ventilator you can adjust specifically to improve oxygenation. We know that the primary problem, the biggest problem in ARDS or respiratory failure is oxygenation. So when your patient is being ventilated, what parameters can you use to improve oxygenation? At the same time, what parameters can you use to improve carbon dioxide elimination? Then we'll go further to talk briefly about some other interventions that you can actually institute to improve oxygenation in ARDS, other than parameters on the ventilator, as well as other interventions that have been known to improve the outcomes in patients that have got ARDS. It's quite a handful of objectives that already sound like too numerous to achieve, but I just want to quickly encourage you to feel free to log into our Learning Resource Center, which covers these topics in a much more detailed form. So the link will be shared in the chat box, and then at your own time, kindly feel free to log into our Learning Resource Center for more details regarding this session. So next slide, please, Sarah. Yeah, so like I mentioned earlier, our case scenario will help us to guide through our discussion. So Mr. T, a 46-year-old man who presents with hypoxemia and respiratory distress, was actually found to be SARS-CoV-2 positive. In other words, he has COVID. So, and his clinical course actually progressed from respiratory failure. He was admitted in ICU, he was intubated, and is currently being ventilated mechanically. So he's on a vent, he's intubated, and is on a mechanical ventilator. So currently his vital signs and other ventilator parameters, they look like this. So the vital signs, the heart rate is 102, the blood pressure is 97/51, the respiratory rate is 35. You can see that it's obviously high. The temperature is 37.5 degrees Celsius, and the saturation is at 90%. So he's saturating at 90%. So what are some of the ventilator settings that Mr. T is currently on? So he's on assist control mode, which means that the ventilator is literally doing all the work, all the breathing for Mr. T currently. And then his fraction of inspired oxygen, or FiO2, is currently 100%. So Mr. T is actually receiving 100% pure oxygen. His respiratory rate again is at 35 breaths per 100% oxygen. His PEEP, which is a positive end expiratory pressure, is at 14. And then the the peak inspiratory pressure, which is the highest pressures as Mr. T is being ventilated, as measured by the vent, is at 40. Okay, is at 40, which is fairly acceptable, but slightly on the higher side. So these are some of the parameters that Mr. T is being ventilated on, giving these vital signs that we have up there. Next slide, Sarah. Yeah, so with that information, we'll get down to the first part or the first phase of our presentation, which is respiratory physiology and respiratory failure. So we'll briefly talk about respiratory failure in the next 1 or 2 slides. And the first question that I would like to ask our participants, or we need to ask ourselves, is that why do we breathe? Why do we breathe? Feel free to drop in some of your responses in the chat box. Why do we breathe? What is the simplest reason as to why we actually breathe? Yeah, so you can feel free to just drop in your answers in your chat box. Yeah, so this question is important for us to understand what we mean when we talk about respiratory failure. What is the importance of breathing? So we're going to watch a very short video briefly, just to give us an idea of why we breathe and what happens during breathing. Sarah, we can't get the sound.
Oh, let me see if I can fix that. Thank you.
Yeah. So why do we breathe? I can already see some of some very important responses, such as okay, still no.
2 bronchi, then branches into smaller bronchioles. The bronchioles end in tiny air sacs, or alveoli. Here, the oxygen in the air you inhale passes into the bloodstream, and carbon dioxide from your body passes out of the bloodstream. The carbon dioxide is expelled from your body when you exhale.
Okay. Yeah, thank you so much, Sarah. Yeah, so that was just a very short video, just explaining some of the responses that our participants have clearly given in the chat box. So we breathe in order for our body cells to constantly be supplied with oxygen. At the same time, waste products like carbon dioxide being removed to avoid pH irregularities. This is one of the responses, which is very, very accurate. We breathe, another response here, so that we take in oxygen for sustaining of life and also take out carbon dioxide. So I think these are very, very accurate responses, and indeed the basic reasons why we breathe. There would be no life. So we know that the oxygen is important for various metabolic processes in the body that result in the production of energy, which is important in order to sustain life. So breathing in ensures oxygenation of blood and tissues. So remember, when you breathe in, you also breathe out, okay? So breathing out allows elimination of carbon dioxide, which is a waste product of metabolism. So it helps to eliminate that carbon dioxide, which builds up from the tissues as a result of metabolism. So that is just really the basic reason or explanation as to why we need to breathe. Next slide, Sarah. Yeah, so now, having understood the reasons, the importance of breathing, how then, what happens when there is respiratory failure? Or in other words, what happens when there is respiratory failure? We are unable to actually ventilate adequately. What really happens? So before we go into those details, I want us to just quickly answer this question. Which one of the following statements about respiratory failure is incorrect? Then we can go into details of respiratory failure. So there you go. So it's a poll. Kindly choose one. We have, I think, under a minute to give our responses. Okay, so we can end the poll. So thank you very much. I can already see that the majority went for answer. So majority. In other words, which of the following statements is wrong? So we can clearly see that the majority, more than 70%, said that answer D, which is respiratory failure, usually resolves on its own. This is the correct answer. So answer D is the correct answer. Well done to all the participants that got this one correct. So answer A, just reading through. So respiratory failure is a failure of gaseous exchange, either oxygenation or carbon dioxide. I think this is just the correct definition for respiratory failure. It's a basic definition and very accurate. Remember that gaseous exchange, you need oxygenation, which is your oxygen going into the blood, and then you also need carbon dioxide elimination. So failure of both processes or failure of either one of them leads to respiratory failure. So answer A is correct. Let's look at answer B. Answer B says respiratory failure can be acute or chronic. That is very correct. So we can have acute respiratory failure, which is the most common form of respiratory failure, and you can also have chronic respiratory failure for those patients who have conditions like COPD, chronic obstructive pulmonary airway disease. So things like emphysema and things like that. So those patients will have chronic respiratory failure. Answer C says respiratory failure is a syndrome rather than a disease. This is correct because for you to define respiratory failure, you need different parameters analyzed together. So you have the clinical parameters, how the patient is presenting, And then you have your biochemical parameters or other vital signs, such as your oxygenation or oxygen saturation, the carbon dioxide concentration in blood. So, so that's answer C. So answer C is correct. Then answer D, like we said earlier on, respiratory failure usually resolves on its own. This is wrong. You actually need treatment for respiratory failure. You need supportive treatment. Your patient needs oxygen, and you also need to treat the underlying cause of the respiratory failure. And then the answer E, patients in respiratory failure may have tachypnea, which is a high respiratory rate. They may have hypoxemia, which is a reduction in the amount of oxygen in blood. And they may present with the hypercapnia, which is an increase in the carbon dioxide content of blood. So this is very true as well. So these are some of the features of respiratory failure. So let's go to the next slide, Sarah. Great. So we are still discussing respiratory failure. So the next question is, list the types of respiratory failure. Okay, list the types of respiratory failure. So kindly drop your answers in the chat box with respect to the types of respiratory failure that you know. Then we can just quickly go through them in a minute or so. So list the types of respiratory failure. What classification do you know of respiratory failure? So kindly feel free to just drop your answers in the chat box. Yeah, so that we can quickly review under a minute. Okay, so there's 2. Okay, so you can give us the names or the actual types that you know of respiratory failure. What are the types? How many? What are the types that you know of respiratory failure? Okay, so we have the mixed type, we have the acute. This one says acute and chronic respiratory failure. Yeah. Okay. We have hypoxia with hypercapnia and hypoxia without hypercapnia. Okay. Good. Another one says hypoxemic respiratory failure and hypercapnia or hypercapnic respiratory failure. Okay. Another one says hypoxemic respiratory failure. Yeah, so I can see so many interesting responses coming out. Great. So I can already see that our participants are quite knowledgeable about this topic. So briefly put together all your responses and actually run through the different types that we have. So Sarah, kindly click on the reference. Yeah, go down on the classification and just enlarge for us. Yeah, so there may be different types of classifications of respiratory failure, and classifications may have changed over time. Yeah, but one type of classification that is easier, that we found easier to interpret is a classification which classifies respiratory failure into 4 different types. So the most common ones are type 1 and type 2. So type 1 respiratory failure, it's also called hypoxemic respiratory failure. So this one is characterized by predominantly a reduction in the SpO2 or your pulse oximeter to detect the oxygenation. So you see a reduction in the amount of oxygen that is blood. So hypoxemic respiratory failure is characterized by a reduction in the percentage of oxygen in blood. So this is usually seen in patients with acute pulmonary edema and several other conditions. Okay, so this disorder interferes with the lungs' ability to oxygenate the blood that's flowing through the pulmonary as the blood flows through the pulmonary vasculature. So type 2 respiratory failure is also called hypercapnic or ventilatory respiratory failure. Remember again, we said that breathing is about breathing in oxygen as well as taking out carbon dioxide. You are unable to take out carbon dioxide you are measuring the amount of carbon dioxide that you are retaining using the arterial blood gas analysis. We are talking about an amount of carbon dioxide which is above 50 millimeters of mercury. Okay, the normal being, the upper limit being up to 45 millimeters of mercury. So this type of respiratory failure is commonly seen in patients with an increased work of breathing, which is due to airflow obstruction or a decrease in the respiratory compliance, or those patients with decreased respiratory muscle power due to several other causes, including neuromuscular disease. Okay, so this is characterized by retention of carbon dioxide because the patient is either hyperventilating or they have other conditions that is making them unable to breathe out adequately. Then the other two types of respiratory failure, we have type 3 and type 4. Type 3 is commonly referred to as a perioperative kind of respiratory failure. And so this one may either be characterized by hypercapnia or hypoxemia. And this is usually maybe related to anesthesia or surgery. So anesthesia related, it may be due to the patient hypoventilating as a result of residual anesthesia. They are still sedated and they are unable to ventilate adequately. And then it may also be due to surgical pain, incisional pain. For instance, if the patient has got an upper abdominal incision and they are unable to ventilate or to breathe adequately because of pain. So they may either fail to oxygenate or they may either inadequately exhale the carbon dioxide. So that's type 3 respiratory failure. And then the last one, type 4, which is cardiovascular related. This is due to or secondary to cardiovascular instability or cardiovascular collapse. A patient in shock, maybe they've got cardiogenic shock, they've got hypovolemic shock, or they've got septic shock. And then as a complication of that, they develop respiratory failure as well. They may start retaining carbon dioxide, or they may be failing to oxygenate their blood. So this is just a basic classification that you can actually use in order for you to identify the specific type of respiratory failure that your patient has. Of course, the most common type of respiratory failure is type 1, and that's what we are seeing commonly in our their oxygen saturations are perpetually very low, and so they need a lot of oxygen in order to support their slide. So when we look at our patient, Mr. T, what So drop your answers again in the chat box. What type of respiratory failure do you think Mr. T is having? Remember, he's saturating at 90 degrees Celsius, 90%. He's on mechanical ventilation, he's breathing, he's being aided. And so what do you think is the type of respiratory failure that Mr. T has? So as we proceed, yeah, feel free again. Yeah, so those are the vitals signs. You can see the saturation is 90%. His respiratory rate also is on the higher side. So what type of respiratory failure do you think Mr. T has? So as we proceed to the next slide, okay, I can already see some responses here, very interesting. Charity says type 1 respiratory failure. Yeah, so there's type 1. It looks like everyone thinks it's type 1. I think we are all very, very correct and we are following each other. So Mr. T actually has type 1 respiratory failure. So then let's spend some time in the next couple of minutes to talk about hypoxemia. Hypoxemia was also covered in a much more detail in our previous sessions. Both hypoxemia and hypoxia, that difference was explained in a much more detail in the previous session that we've held a couple of months ago. So once you log into our Learning Resource Center, you access that material and you understand hypoxemia versus hypoxia in a much more detail. So in this slide, we shall just sort of discuss the summary of
Dr. Sipuka, we can't hear you.
Can you hear me now?
Yes, now we can hear you.
Okay. Apologies for that network blink. Yeah, so we are discussing hypoxemia. So we know that hypoxemia is actually a feature of respiratory failure and a common cause actually of mortalities for patients that present with respiratory failure. So it's actually the easiest way to recognize a patient in respiratory failure. So we know that hypoxemia can be detected or defined or monitored using two ways. There are two ways in which you can detect hypoxemia. The first one, you can use pulse oximetry, and the second one, you can use a blood gas analysis. So Sarah, just click on the first one. How is hypoxemia defined using blood gas? Using pulse oximeter. We know that, up a bit, please. Yeah, so we know that a pulse oximeter can actually be used. It's the simplest and quickest way to detect a hypoxemia. Okay, it's non-invasive, it's quick to use and very easy to interpret. And pulse oximeters are now all over in our health facilities. We know how to use them. And so it's very easy to detect hypoxemia using a pulse oximeter. So we know generally that any patient who is saturating at less than 94%, that patient has hypoxemia. So generally, hypoxemia is an SpO2 of less than 94%. Okay, normal SpO2 is supposed to be above 95. And so any patient who is saturating below 94%, that patient has hypoxemia. And so that's the quickest way of defining hypoxemia using a pulse oximetry. And so remember, again, the pulse oximeter can also help you monitor the patient's response to oxygen therapy. It can also help you decide, of course, which patients will need oxygen. So I'll quickly refer you to our Learning Resource Center again, so that you go through our material and appreciate what their limits, or rather criteria, for oxygen therapy for different categories of patients, such as those patients in ARDS, those patients that are in shock, very sick patients. What are some of your goals of SpO2 treatment goals, etc., etc. So we can now quickly turn to how we define hypoxemia using the arterial blood gas. So we can revert Sarah. Okay, scroll down. Yeah, keep going. Okay, keep going, keep going. Yeah, just there on the results reporting and critical findings. Okay. Okay, so I mentioned again that, go up, Sarah, on the results and critical findings. Yeah, keep going. Yeah, just there, just there. Yeah, you can enlarge that this slide for us. So again, we mentioned earlier that the other way of defining hypoxemia, other than using the pulse oximeter, is if you are able to do an arterial blood gas analysis. Now, there are very few of our institutions are actually privileged with an arterial blood gas machine that's able to do an arterial blood gas analysis. So if you have access to the arterial blood gas machine, it can also help you to diagnose hypoxemia using what we call the arterial partial pressure of oxygen. We know that the arterial blood gas is a more arterial partial pressure of oxygen, the arterial partial pressure of carbon dioxide, bicarbonate, and several other metabolic parameters. So with respect to oxygenation, we look at the arterial partial pressure of oxygen in order to define hypoxemia. So if you look at the arterial blood gas analysis and your partial pressure of oxygen is less than 80 millimeters of mercury, then that patient has got hypoxemia. So we look specifically at the PaO2. Okay, PaO2, the normal range is 75. Other literature will say from 80 to 100 or 75 to 100, or more or less the same. So if your PaO2 is less than 75 or 80, according to other literature, that patient has got hypoxemia. So these are the different methods that you can use to define hypoxemia. If you have an arterial blood gas analysis, or you are able to, you can use the pulse oximeter, which is the simplest and quickest way of detecting that. So we can go back to the main slide, Sarah. So that is briefly how you can use your pulse oximeter as well as the arterial blood gas analysis to define hypoxemia. So again, feel free to log into our learning resource center to access these materials and understand them in a much more detailed manner. So part one is over. Thank you so much for your attention. So at this point, we'll move on to defining ARDS. Okay, so I'll invite my colleague, my co-presenter, Dr. Piri, who is going to take you through the next session on ARDS. Dr. Piri, are you there?
Yes, I'm here, Dr. Spuka. Thank you. Okay.
Kindly carry
on. In this
on.
segment, we'll be looking at the actual. Before we look at the actual definition or what the letters ARDS stand for, I just want us to review what Dr. Spuka mentioned. ARDS, I think we've been told, this is a consensus agreement. It's a consensus definition, a new definition on medicine. This was only coined, the definition that we're using now is from 2013. So the phenomena of ARDS is something which was recognized in 1967 in ICU patients. So as we go through this segment, I'm going to ask our participants, what do you think the letters ARDS stand for? Sarah, can you poll our answers? Please carry out a poll for us. Okay, thanks. Sarah, can you end the poll? Okay, so looking at you went for acute respiratory distress syndrome. I think this was just a red herring. I think most of us know that we're talking about acute respiratory distress syndrome. So in this segment, yes, in detail. Sarah, can you please scroll downwards? Okay, thank you. So as I mentioned, ARDS is consensus agreement. This phenomena was noticed in 12 ICU patients. I think this was way back in 1967. No matter the underlying etiology, the presentation of these patients seemed similar. And we have come a long way from 1967 up to now. The current definition that we're using is the Berlin definition of ARDS. We'll break it down a little. We know that for the Berlin definition of ARDS, which is a consensus agreement, there are 4 components which must be met for the diagnosis of ARDS to be made. And please, as you make this diagnosis, it is somehow a diagnosis of exclusion, and you'll see what the caveats are. So there are 4 aspects to it. Sarah, can you please click on the link? Okay. So as we said, this is a clinical diagnosis, and there are several parameters which must be excluded for you to make the diagnosis of ARDS. Now, 1, you must have, please scroll upward, Sarah. Please go up. I think you're at the bottom of the page. Can you scroll up? Okay, I'll go on while Sarah is trying to find the part that was supposed to be projecting. So the first part is that you must have respiratory symptoms. Remember, we're looking at a respiratory condition. So typically, in the consensus agreements that we have, both the Berlin criteria of 2013 and other modifications, these respiratory symptoms must be of acute onset. So typically, this is the cutoff, which is put is 1 week. So this is 1 week after an obvious clinical insult, or 1 week after worsening symptoms for a patient who is admitted. So that is one aspect, the respiratory symptoms. The second component, which must be met to make a diagnosis of ARDS, are bilateral opacities. In the Berlin criteria, these bilateral opacities must be seen on chest X-ray or CT scan. And the caveat here is that these bilateral opacities should not be explained by a pleural effusion, a lung collapse, or they should not be pulmonary nodules, they should not be a lobar collapse, neither should they be defined by your congestive cardiac failure. So that is the second component to make a diagnosis of ARDS. The third component, the third key in your diagnosis is your respiratory failure. So here you have oxygenation and ventilation problem, and this is a respiratory failure which has arisen in your patient, and it is not fully explained by fluid overload or congestive cardiac failure. Obviously, for this you're looking at, as a clinician, you should be able to make this judgment with the help of echo or with clinical signs. So respiratory failure, which is caused by CCF, neither is it caused by fluid overload. The fourth aspect, the fourth arm in your diagnosis of ARDS is your moderate to severe impairment of oxygenation. This must be present, and this is the last prong for you to define what ARDS is. Sarah, can we please go back to the main presentation? Okay. So for more details on the definition, the Berlin definition, visit the Learning Resource Center. All of these resources are there. I apologize, I think my internet is a bit shaky, so if I go on and off, it's because of my internet connection. Sarah, please scroll downwards. Okay. So what is this? What we've looked at is the literature, and we've looked at the consensus agreement. But how do you put this into practice when you have a patient before you? So we have what we call the P to F ratio. And here, we'll look at what the PF ratio is, because this is a very important aspect in the management, in the definition of ARDS. How do you calculate the PF ratio? So as we look at this definition, or as we look at this calculation of the P to F ratio, we'll have Mr. T in mind. So bear in mind, please keep these figures. If Mr. T, the patient who is before us, has an arterial partial pressure of oxygen, which is equal to 60, obviously this is from an ABG result, and his ventilator, if he's being invasively ventilated on CPAP, his ventilator is set to deliver 80% of oxygen. How do you calculate then his P to F ratio? So two parameters that we've been given so far, the partial pressure of oxygen, which we derive from an arterial blood gas. And then the ventilator is delivering 80% of oxygen. So how do you translate this into a ratio? Sarah, please click on the link. Okay, you can zoom in for us so that the participants can appreciate this. So the P to F ratio, this is the ratio of our arterial oxygen tension to the fraction of inspired oxygen that the patient is getting. So this is a very important ratio. One, it's important in gauging or calculating the severity, grading the severity of your ARDS. So how do you go about calculating this? So it's quite simple. If you have your partial pressure of oxygen given from your ABG, which in this case is 60 for Mr. T, you that by the fraction of inspired oxygen. We know that room air is 21% oxygen. So when that is expressed as a fraction, that is 0.21. But for Mr. T, who is on a ventilator, we are told that he's getting a fraction of inspired oxygen of 80%. So as a fraction, that is 0.8. We're going to divide the partial pressure of oxygen that Mr. T is on, which is 60, divide by 0.8. If you do that on your calculator, what you're going to find is that for Mr. T, in this particular case, his P to F ratio is actually 75. So what does this mean? What does this mean clinically? You have a patient before you and you have calculated that fraction, but how does that help you to calculate or define whether you have ARDS and how much? What is the severity of the ARDS? So we can go back to the main screen. Please visit this page later on. We can go back to the main screen, Sarah. We'll be going back and forth. Okay. So on the reference material that we're looking at, we're seeing how to calculate the P to F ratio. So we found that for Mr. T, his P to F ratio is 75. But what does this mean in terms of defining ARDS? How do you use this information, this calculated ratio? So this P to F ratio, it helps to determine the extent or the severity of the ARDS that Mr. T has. So ARDS has been classified into 3. We have mild, moderate, and severe ARDS. The calculation is what we just went through. How do you determine? We went through this just from before. But there are several parameters. Sarah, I'll ask you to click again. We go back to our reference material. So how do you define, having ratios, how do you know what is mild, moderate, and severe? So for Mr. T, whose P to F ratio is 75, if you look at reference material, this P to F ratio of 75 is less than the cutoff point of 100, which has been put in place. A P to F ratio of less than 100 defines severe ARDS. So I'll just look at the reference material. For mild ARDS, your P to F ratio must be greater than 200 millimeters of mercury. But if your patient is on a ventilator, this is slightly adjusted. So this is you take the upper limit of 300. So 200 to 300 if your patient is on a ventilator. And this is a patient who needs PEEP. PEEP, we've discussed in previous session. This is when you're actually using positive, where you're actually using positive airway pressure as you are ventilating your patient. We know that normal inspiration is negative pressure driven, but for the mechanical ventilation, you're talking about positive end expiratory pressure. So you're actually adding pressure for you to sustain your breathing. Okay. So for your mild ARDS, PF 200 to 300 for those patients who are being mechanically ventilated. For moderate ARDS, your P to F ratio should be less than 100, but less than 200. So we're talking about between 100 to 200 if your patient is on a ventilator. So the upper limit is for a patient who is on a ventilator and requires a PEEP, positive end expiratory pressure greater than 5 centimeters of water. So this is a patient who really, you're pushing, you really need to drive that air in. You need to push in the air with positive pressure for you to achieve effective ventilation. While for your severe ARDS, which is what we've graded our Mr. T to be in, the P to F ratio is less than 100 millimeters of mercury on a ventilator, and the PEEP must also be greater. If he's on a ventilator, the PEEP must also be greater than 25 centimeters of water. So in a nutshell, you have to remember that we've got there are 3 severities: mild, moderate, and severe. Mild, you're talking of 200 to 300, moderate, between 100 and 200, and your severe is less than 100. The calculations we have gone through. Okay, Sarah, can we go back to the main presentation, please? Okay, scroll down for me. Okay, so as we discuss this ARDS, I think if there's something that you looked at that we all noticed as we were looking at the definition, the Berlin definition of ARDS, what happens if you do not have an ABG? Does it mean you're not able to make a diagnosis, of ARDS? What if you do not have access to a CT scan? Does it mean you are not able to make a diagnosis of ARDS? There have been several modifications which have been made since the original Berlin criteria to try and help physicians or clinicians who are in resource or variable resource settings to be able to make the definition of ARDS. For instance, there is a Kigali modification. Sarah, you can click on the link. So several modifications have been done of the original Berlin criteria of ARDS, and all of this is to ensure that even in variable or limited resource settings, ARDS can still be diagnosed using surrogates. So really, in terms of the epidemiology of ARDS, there's no data in terms of the prevalence in the developing world because of the definition constraints which are there. The clinical definition itself makes it difficult for you to use this when you don't have pulse oximetry, when you don't have access to an arterial blood gas as well. You actually need to have, according to the original Berlin definition, you need to have access to positive pressure ventilation, you need to have an ABG, you need to have access to X-ray services, but we know that in our setting, this is not always there. So the Kigali modification is something which has been modified to make it easy in resource limited settings. So here, this definition excludes, there's no need to consider IPPV. However, you still need to use your pulse oximetry, and you can use your chest X-ray or ultrasound, as CT scan may not always be present. So here, what are the differences between your Berlin and your Kigali definition? So first of all, there is one thing. There are four aspects to it. What makes it different? So if you look at the timing is still acute. So 1 week for both definitions. There is no modification which has been put in place. However, the biggest modification which is there is in terms of assessing the oxygenation of the patient before you. So our P to F ratio, our partial pressure of oxygen in arterial blood, to our FiO2, our inspired oxygen. With the Berlin criteria, we know that for you to make a diagnosis of mild, we said this must be less than 300. However, in the Kigali modification, we use pulse oximetry instead of arterial blood gas. So the pulse oximeter value that you have before you, when you put it on your patient, divide by the fraction of inspired oxygen. So here, the upper limit is 315. And this has been researched. I think there are various studies which have been put up on the Learning Resource Center, which validate the use of this Kigali modification. This is the biggest, I think this is one of the biggest modifications in terms of Berlin to Kigali for low resource settings. In terms of PEEP, in the Berlin criteria, the minimum PEEP which is put is 5 centimeters of water if your patient is mechanically ventilated. However, in your Kigali modification, there is no need to consider PEEP, as in most low resource settings, patients may not be invasively ventilated. In terms of imaging, with the Berlin criteria, the emphasis is on our chest X-ray, looking at bilateral opacities on chest X-ray or CT scan. However, with the Kigali modification, these bilateral opacities could be found on chest X-ray or ultrasound. And as usual, these are opacities which are not explained by the causes which were earlier mentioned: effusions, lobar or lung collapse, or nodules on X-ray. For both Berlin and Kigali, the origin of edema must be respiratory. So this is a there should be non-cardiogenic causes of the opacities or of the respiratory failure. So this is a respiratory failure which is not fully explained by CCF or fluid overload. Okay, so I hope we're able to appreciate how you could use this modification in our low resource settings. So using the Kigali modification. Sarah, can we go back to the main slide? Okay. So lastly, we're going to talk about what happens in the lungs when a patient is diagnosed with ARDS. What is the actual insult on the lungs during ARDS? So there are three pathophysiological changes which occur in lungs which are undergoing ARDS. Sarah, you can click on the link. Okay. So as I mentioned, all of this material is there on the Learning Resource Center. Please find time to peruse through so that you could understand. I'm not a pathologist, but I'll just go through in a nutshell. So there are various time limits which have been put to quantify the stages, and these have been correlated with the post-mortem studies or lung biopsy studies of patients suffering from ARDS. Why are we talking about ARDS today? We know that COVID pneumonia can complicate into an ARDS. We have seen this. I think we know that this is one of the scariest complications of COVID pneumonia. So in the initial stages, this is called the stage of diffuse alveolar damage, or DAD, D-A-D. So this is the early exudative stages. You have a lot of inflammation happening in the lung. Typically, this is our 1 week, so 7 to 10 days after 7 to 10 days after the actual insult or worsening results. So this is diffuse alveolar damage, non-specific injury to the lung. It's a non-specific reaction, but it's all over the lung. It's diffuse. What is it characterized by? The same hallmarks of inflammation. So you've got edema, you've got interstitial edema, you've got acute and chronic inflammatory cells, you've got type 2 cell hyperplasia, you've got formation of a hyaline membrane. So this happens in the early stages, about day 7 to day 10 of the clinical insult that the patient has had. So the stage of DAD, diffuse alveolar damage. This is the histological hallmark. If you were to send a patient lung biopsy sample to pathology, that's what you would see. The next stage is a fibroproliferative stage. Here, what you have is that, of course, the time limit or the time frame to this is not really specified, but typically 2 to 3 weeks after the initial insult. And if you look at our patients who come in with COVID pneumonia, COVID ARDS, we've seen a lot of these patients who are coming in from day 14 to day 21, post the initial injury. So here, what you have is that your initial pulmonary edema could be resolving. You've got proliferation. You've got proliferation of our type 2 alveolar cells. You've got metaplasia, squamous metaplasia. You've got interstitial infiltration by myofibroblasts. So you have all of these changes happening in the lungs. The last stage is the fibrotic stage. And these patients, we're still seeing them. A patient had COVID earlier in the year, in the first quarter, but you see them in the third quarter and they still have respiratory symptoms because they suffered ARDS and they healed with fibrosis. So in the fibrotic stages, you have a lot of changes happening in the lung. So patients who actually progress to fibrotic stage, they'll have obliteration of the normal lung architecture. So there is total collapse of the normal lung architecture. You've got fibrosis, which can be seen. Cysts may form as well. And the degree of this fibrosis is very varied. For some, it is minimal, while for others, it is very severe. So this may explain some of the symptoms that our patients are coming in the early stages of their COVID pneumonia and COVID ARDS, when we see them a good 2 to 3 weeks later, when we term them to be in probably a storm, and then the long COVID patients that we're seeing. Okay. Sarah, can we scroll down? Okay, I think at this point, allow me to hand over. We can show the video, and then I'll ask Dr. Papytcho to take over after this. So please, let's just play the video, the short clip. Okay, I didn't seem to have sound there, but please, participants, you're encouraged to visit the Learning Resource Center anytime to view the videos or any of the contents from this presentation. At this point, I'll hand over to Dr. Papytcho Ntambwe. Dr. Ntambwe, are you with us?
Thank you very much, Dr. Op. Thank you for the nice presentation. We'll continue it up. Now, after going through the pathophysiology and clinical presentation of ARDS, it's time to focus on another aspect, which is management in terms of mechanical ventilation. In this, we'll try and talk about few parameters that are involved when doing mechanical ventilations. But before we go further, we would like to bring up a point by saying treatment of ARDS, it simply consists of an appropriate treatment for underlying or causative illness. Remember, ARDS is just a complication. Even though you are treating ARDS, remember to take care of the underlying condition. Secondly, this patient needs a supportive care, a complete support care. So you give them full nursing, full medical care that they deserve. And thirdly, you want to prevent complications associated with mechanical ventilation. So can you scroll up and then, thank you. These are a few parameters that are involved when doing the settings on a mechanical ventilation when it comes to dealing with COVID. I mean, with any patient who's meant for ventilation. Remember, on a ventilator, there are set parameters and rate parameters. You enter a parameter, you enter a value for each parameter, and the ventilators will give you the measured parameters, what it has delivered. Few terminology that are usually involved when doing the settings. One is a tidal volume. How do you define tidal volume? You remember from the physiology, respiratory physiology that we learned, tidal volume is simply the volume of air inhaled or exhaled in one breath at rest. When you check on the ventilators, you find that most ventilators will give you a settings for tidal volume. You enter the settings, and then what is the normal range? The range of tidal volume is said to be between 6 to 8 for normal ventilation. But with regard to ARDS, we'll discuss later on what is called lung protective mechanical ventilation strategy. First, we can finish up with the definition of the parameters. Second parameter that we would like to talk about is the FiO2, fraction of inspired oxygen. Usually, we do confuse this with SpO2, peripheral saturation. The FiO2, it's a percentage of oxygen available for inspiration. Remember, as we are breathing from the room, and for the air atmosphere, the concentration or percentage of oxygen is 21%. But now when you are dealing with your patients, giving them oxygen from the cylinder, we expect that oxygen to be pure, and then the concentration should be 100%. So now, when you're setting your ventilator, there's a setting which is called FiO2, giving a provision for you to set between 21 to 100%. Remember, as an individual in good condition, when breathing on room air, we breathe at 21%, but when you check your SpO2, your saturation, it can show you that you are breathing normally, and then the saturation is at above 96, and then you are normal at 21%. Now, during ventilation, if for you to achieve good saturation, you need a highly concentrated oxygen, then there's a challenge with oxygenation, or a challenge at gas exchange level. And this is what happens mostly with ARDS patients. Because of the inflammation, the tissue changes, the pathophysiological changes, the fibrosis, and all those changes that occurs, the edema and everything, as we discussed earlier on, there's impaired gas exchange. So you want to maximize the availability or the concentration of oxygen so that you try and improve oxygenation and get a better saturation. You found that when starting ventilation, you start it at 100 and above. I mean, 40 and above, up to 100 as the highest limit. But when patients start getting better, remember to start weaning your patient by reducing your FiO2, going closer to the normal FiO2 that we use during respiration with room air. The other parameter that we'll look at is the plateau pressure. When you check your ventilator, you might not see it written there, plateau pressure. But when you go in the settings, this is the measured parameters. How do you define the plateau pressure? It's the pressure at the end of inspiration in the alveolar. So how do you get the plateau pressure? On your ventilator, there's an option of a pause, inspiratory pause. When you press the button, the vent will go into a pause mode at the end of inspiration after pushing in oxygen into the lung, and then at the end, it will go into a pause mode. It takes 3 to 5 seconds as it's measuring the pressure inside the lungs at the alveolar level. This corresponds to the static compliance. It wants to tell you what is the compliance of the alveolar at this time when I'm measuring it. And the ideal pressure when doing ventilation, it should be less than 30 centimeters of water in an ARDS patient. The other parameter that we'll talk about here is the PEEP, positive end expiratory pressure. This is the pressure at the end of expiration in the lung, in the alveolar. This is a parameter that you set. As you enter this parameter, remember, patients complicated with ARDS, as it was discussed earlier on, the alveolar are inflamed. There's interstitial and alveolar edema that occurs, which cause collapse of the dependent alveolar units. So in this time, you need to do what is called recruitment maneuver using your PEEP parameters. By recruitment, what does it mean? You want to go select the alveolars that were collapsed due to edema or compressed by the interstitial and the alveolar edema or the tissue edema, so that they start participating to the gas exchange. And the better the number of alveolar that you'll recruit using the PEEP, it will improve your saturation. So the recruitment maneuver, you start with a low PEEP and then going up, checking on the patient response. Having in mind that the higher the PEEP, there are also other complications that can come along. The one that we mentioned earlier, the barotrauma. Remember, these are teeth tissues, the alveolar fibrotic. If you exert again more pressure on them, the tissue can tear and then cause more complication. The next parameter that we can define is driving pressure. Driving pressure is basically the difference between the plateau pressure and the PEEP, positive and expiratory pressure. It's also known as a compliance pressure. It wants to show you the difference between the two. So when the gap is too big, meaning you need more pressure for you to ventilate your patient. The gap between the PEEP and the plateau pressure should be just within a normal range. And during ARDS, your target is to have a driving pressure of about 14 to 18. When you're getting such a difference and then getting good saturation, you are good. But if the gaps start getting bigger, then it becomes a bit wrong. The last parameter to talk about is the peak inspiratory pressure, which is simply the highest pressure that you measure during inspiration along the airway. This one is a measured parameter. The ventilator readings, when you check on the measured parameters, it will show you what is the peak pressure. The acceptable range is a maximum of 40 centimeters of water. If you get it above that, it shows that there's so much pressure, and then you are ventilating your patient at risk of causing more damage to the airway. So just a brief comment on the terminology of lung protective mechanical ventilation strategy. Remember, as we said earlier on, when doing your lung, your tidal volume, the ideal one is between 6 to 8 mils per ideal body weight. But because you cannot get ideal body weight, we can use the predicted weight. Now, studies have shown that when using that much, you are causing more stress and strain to the already inflamed alveolars, and then causing more biomarkers being released from the alveolar tissues, worsening up the condition of the patient. Your target here is to deliver very minimal tidal volume. So you go almost to half of what the patient should get. 4 to 6 mils per kg is ideal, and then it will reduce ventilation-induced lung injury compared to the normal tidal volume. Thank you, Sarah. We can move to the next page. As we said, the treatment is a type of holistic management that you are doing. There have been queries to know if neuromuscular blockades for severe ARDS was useful or not. Sarah, please click on the link. There are different schools when it comes to use of neuromuscular blocking agents. There are pros and cons. As we know, for ICU patients, the ideal to do is to sedate them. Ventilating them with sedation is best than ventilating them when they are paralyzed. Paralysis can give you an improved oxygenation because patients to very still and then not move at all, especially if you run it as an infusion. And remember, the more you paralyze your patients, remember that drug have to be excreted and eliminated. And this patient can have also other multiple organ failure. So time for elimination can be delayed, and then it will be prolonged neuromuscular weakness, and then patient might have problems in recovery when it comes to weaning. Those are the challenges that you might face with paralysis. So several studies were done to compare the two. It has found that it's best if you can to avoid paralysis and keep patients in a good sedation so that you have a chance of easily and quick recovery when you decide to wean him from ventilation. Thank you, Sarah. Next stage. So the management of this patient is not only about ventilation, but there's also fluid management. I know in this forum we've got physicians with different opinions. It's true, we have challenges here. You want to go liberal or you want to be conservative in terms of fluid administration. There is an increased vascular permeability, as we know, which leading to edema in terms of ARDS. And the quantity of edema formed depend directly on the hydrostatic pressure than the oncotic pressure. So adding more fluid, meaning there will be shift again from fluid from the vascular bed into the interstitial, worsening up the condition by making it more edematous. So now here comes another challenge. Restricting this patient from fluid, you might go into negative balance, and then already patient is having problem with organ perfusion. It might end up with a poor organ perfusion and poor circulation. In a certain randomized control trial study, where they were comparing conservative versus liberal, it was found that when using a central venous pressure of 4 as target and pulmonary artery occlusion pressure of about 8, they found that patients had quick recovery and better improvement when it was in a conservative fluid strategy. Why? Because of the reason that we advanced earlier on of avoiding to cause more edema. But have in mind that as a clinician, when you're doing your conservative, you have to have in mind that patients should not be into hypotension or they should not be organ hypoperfusion. Otherwise, you'll be in a vicious cycle, ending up with more complications than you would like the patient to be. All this information, you will find them on the links that is attached to this discussion point. So at your own free time, please find time to click on the link, and then you have access to all the information. The other point to discuss, which we said it earlier in some other presentation, it's about prone position, treating or ventilating patients in prone position. The advantage of prone position over supine or lateral position in patients with ARDS is now taking wide choice among the physician who are ventilating patients. It has been demonstrated that patients who are in prone position have an improved oxygenation level compared to patients who are ventilated in a supine position. Why? Because during prone position, there's edema fluid redistribution and also recruitment of alveoli, which is more easily achievable when the patient is in a prone position. That is why prone position works better than the supine position. And it's more effective when you start putting prone already by the beginning. When you notice that my patient is going into ARDS, let me start proning him so that you keep on redirecting the fluid that is moving from the vascular level. Instead of it going into the alveolar, it moves out of the alveolar, it goes into other tissues, but leaving the surface area for gas exchange free. Yeah, so the patient benefit must be considered despite possibility of complication that can come with a prone position. Remember, doing prone position, for the period that you prone position, the recommended, they say minimum should be 12 hours. Remember, for 12 hours, you are not changing patient condition. So there's risk of lines or the tubes to be dislodged. There's risk of pressure sores, but having a pressure sore on a patient and then being able to wean a patient from a ventilation, it's better than having a patient without pressure sores and not being able to wean him from ventilation. So prone position, it's a highly recommended position in early phase of ARDS during ventilation. Remember, even for non-ventilated patients, you can still put them on prone position when you realize that they are having ARDS. Thank you, Sarah. So this is a video, it's a short video that shows how to put a patient in prone position.
Proning an ARDS patient receiving invasive mechanical ventilation in the ICU must be done carefully to ensure safety during the procedure. For the procedure to be successful, it is vital to use trained and experienced staff. The video you are about to watch shows the technique used to achieve the prone position and the return to the supine position. The procedure usually requires 3 to 4 people. One person remains at the head of the bed to secure the endotracheal tube and the ventilator lines. This person coordinates the procedure. The other people position themselves on each side of the bed. The procedure is performed following 5 steps. The first step is to prepare the procedure. At this stage, you have to decide which direction to turn the patient, to the left or to the right. Priority is given to whichever side the central venous lines are located. Check the length of the vascular lines and the transcutaneous saturation cable to be sure they are long enough. Move the ventilator as close to the patient as possible. Check the patient's hemodynamic status and the level of sedation. Secure the endotracheal tube and the gastric tube. Protect the skin on the forehead, knees, iliac crests, and thorax from pressure sores using adhesive pads. Protect the patient's eyes and get the electrocardiogram electrodes ready for use. The second step is to move the patient horizontally. Then, they are moved towards the opposite side. From the side, they will subsequently be turned towards laterally by pulling the bedsheet. The patient should be moved towards the side of the central venous line. After moving the patient sideways, the hand on whichever side they will be rotated onto is placed under the buttock. A new bedsheet is also prepared along the length of the bed. The third step is a side lie. The patient is rotated laterally in a full side lying position. The patient is maintained in this position for a short time while one person removes the electrodes from the anterior thorax and another person attaches the new electrodes to the back. The fourth step is complete proning. The new bedsheet is used to pull the patient and to move them into the final complete prone position. The body is placed in a horizontal position at 180 degrees. The abdomen is usually not supported. The upper limbs are placed alongside the body. The fifth step is post-proning installation. The patient is moved to the center of the bed. The head is turned laterally and moved every 2 hours. The endotracheal tube must be easily accessible. Care should be taken to close the eyelids tightly and avoid ear kinking.
Thank you, Sarah. Another point in the management of this is use of pulmonary vasodilators. Sarah, please a bit down. Thank you. True or false, there's ample evidence that inhaled pulmonary vasodilators such as inhaled nitric oxide and inhaled prostacyclin improve mortality in ARDS. It's true for those who are capable or in possession of these. These two, they cause vasodilatation of vessels and improving good perfusion of the area that are oxygenated and improving oxygenation. And this can lead to improvement of general condition. Now, comparing nitric oxides and prostacyclin, nitric oxides got a harmful effect on the kidney. So that's why in the area where they are capable of giving it, they will prefer giving prostacyclin, which is easily given without any special equipment needed, than nitric oxide being a bit more cumbersome. You have to be a bit special kind of inhalation providing device for you to send it down to the alveolar level, absorbed, and then for it to be able to vasodilate the vessels. So it's true, it can help improve the general condition by causing vasodilatation and at the same time improving the general condition of the patient. Dr. Sipuka, I think we are done with the treatment of ARDS. We leave the floor to you.
Okay, thank you so much, Dr. Papytcho and Dr. Hope. I hope this has been very, very useful for our participants and listeners. I think I would only encourage them again to get to the link, open it, and read the details, much more details that we haven't actually been able to cover in the short time that we've had. Yeah, so in conclusion, Sarah, just go up a bit. We are not going to have the breakout sessions. Sorry, down, Sarah, sorry. So we are not going to have the breakout sessions. but I would like to leave you with two sort of scenarios or objectives to think about. So now that we've gone through this discussion, as a participant, how do you think you would change your practice for ARDS patients? Do you think now you have the information, and how would you utilize this information to sort of change or apply in your practice as you take care of these of patients with ARDS? The second question is, what interventions can be employed even when an ICU setting is not available in your facility? I know not all facilities have got ICU, settings. Some have an HDU and others don't. But what are some of the interventions that you can do for ARDS patients if you do not have an ICU in your facilities? What are some of the things that you can do for those patients? So these are just the two quick questions that you can reflect as you also try to assimilate what has been discussed today. So just to conclude again, I'll just quickly recap on the practice change of objectives that we had intended to achieve at the end of this session. We hope that you are now able to define respiratory failure as well as listing the different types which exist. You are also able to define hypoxemia using pulse oximetry, as well as using an arterial blast gas analysis if you have one. You are also able to define the criteria for ARDS, okay, and also apply the Kigali modifications to diagnose ARDS, which is much more applicable in resource-limited environments, like was discussed earlier. I'm sure you're also able to grade the severity of ARDS in terms of mild, moderate, and severe. You also have a bit of understanding now on the pathophysiology of ARDS, and also you are able to describe some of the principles of lung protective ventilation. Hopefully you also know what kind of parameters on a ventilator that you can adjust to improve oxygenation, as well as improve carbon dioxide elimination. You are also able to apply other interventions to improve oxygenation other than ventilator parameters, and also other interventions that can improve outcome in patients with with ARDS. So with those practice change objectives, I hope that you've had a good time with us. And so we look forward to being with you in our next session. This time, I would like to invite Assist Sarah just to conclude, to give us any conclusive remarks before we close.
Yes, thank you, Dr. Sapuka, and thank you to all of our panelists, Dr. Papytcho and Dr. Hope. It was an excellent session. Thank you all for joining us today for this excellent information. So just a reminder that you can access all of the presentations from today, the slides, the recordings, all of the resources that were shared are free. They're online on the Learning Resource Center. You just go and make an account and you can access all of this in the future. All the links to the LRC and the session recording will be shared by email after the session and follow-up email. And then there is access to certificates of participation if you would like to have one of those. That will also be circulated by email later this week, hopefully. If you would like to join our WhatsApp group, we have one. Please scan this QR code here, or you can message Assist at the phone number below. We hope that you'll join us next time for session 9. It'll be on September 16th, and we'll be talking about pediatric considerations for oxygen and critical care. If you have any questions whatsoever, please email us at echo@assistinternational.org. And thank you to all of our sponsors, to Echo India for being here today. Thank you to our panelists and all the universities that have participated in this. Thank you very much. Have a great rest of your day, and we'll see you next time.